This is a presentation on man-in-a-barrel syndrome. It was created by Natalie, Ellie, Kathy, and Elena. For our patient case, we have a 58-year-old male with a history of hypotension. He has been admitted to the emergency department for cardiac arrest. His MRI shows a loss of blood flow to the distal branches of the anterior cerebral artery and the middle cerebral artery. Upon occupational therapy evaluation, weakness in the bilateral upper extremities is found. The client also presents with maintained strength in the cervical and lower extremities. What is the most probable diagnosis? Man-in-a-barrel syndrome is a neurological syndrome that involves bilateral upper extremity weakness with preservation of the lower extremity, facial, and neck muscle strength. One's body appears to be stuck in a barrel by the way the client's arms and torso will atrophy. Man-in-a-barrel syndrome can be caused by cervical medullary infarct, bilateral watershed strokes, or any lesion affecting the bilateral upper extremity motor fibers. The watershed zones, or the distal branches of the anterior cerebral artery and the middle cerebral artery, are mostly affected in this disease. If these watershed zones do not receive the right amount of oxygenated blood, the cells in the area will die. This leads to damage in the bilateral upper extremities, causing the weakness observed in these clients. This bilateral symmetric damage is isolated in the upper extremity motor fibers. This syndrome can affect the corona radiata, internal capsule, basal ganglia, brainstem, anterior spinal cord, cervical nerve roots, brachial plexus, peripheral nerves, and/or the neuromuscular junction. Reflexes can also be affected in several ways. If the patient has a lesion or a central nervous system injury, reflexes are brisk. If the peripheral nervous system is affected, reflexes may be absent. Diagnosis and medical treatment. To be diagnosed with man-in-a-barrel syndrome, the individual must undergo evaluation and neurological examination. Bilateral arm strength must be found to be impaired, and bilateral cervical, facial, and leg strength will be preserved. For patients with watershed stroke, treatment includes maintaining adequate blood pressure to prevent extension of stroke, evaluation for any arterial stenosis which may have predisposed to hypoperfusion, initiation of antithrombotic medication, and correction of the underlying abnormality causing hypotension. For compressive cervical spine lesions, emergent surgical decompression should be considered. Intrinsic cervical spinal inflammatory conditions can be treated with steroids. Physical therapy and occupational therapy treatment are important to help improve functional recovery in man-in-a-barrel syndrome. Man-in-a-barrel syndrome can cause complications with cognition, sensory and language dysfunctions, motor and sensory deficits in bilateral upper extremities, muscle weakness and spasticity, and in some cases, bowel and bladder dysfunction. Preserved strength is found in the neck, face, and bilateral lower extremities. Functional mobility, grooming and hygiene, bathing, dressing, feeding, driving, meal preparation, and shopping are all the ADLs and IADLs that an individual can face challenges to performance in as a result of this syndrome. Due to the weakness and/or spasticity in the upper extremities, engagement in these activities can be heavily influenced. Several body functions, including gripping, manipulating, lifting, holding, coordinating, and moving, are impacted. Individuals with more severe motor deficits in the bilateral upper extremities will have less successful occupational performance. Occupational therapists can work together with physical therapists to assist in restoring the client's ability to succeed in performance-based activities through various interventions and techniques. Many occupational therapy approaches to intervention can be used when working with individuals diagnosed with man-in-a-barrel syndrome. These interventions include the establish and restore approach, the maintenance approach, and the modification approach. The use of passive and active range of motion exercises can help restore range of motion in the upper extremities. This increased range of motion can facilitate the functional restoration of the brachial plexus. Restoring the client's strength in his upper extremity muscles, such as the biceps brachii, brachialis, coracobrachialis, and deltoid, as well as the client's grip and object manipulation skills, will assist with his level of engagement in activities of daily living. The maintenance approach will allow occupational therapists to provide supports to the client that will assist them in continuing to participate in their activities and to meet their occupational needs. This may include providing environmental modifications or the use of assistive technology. The occupational therapist could add modifications to the client's activities to revise how they perform their activities of daily living to support their overall performance. For example, this could include the use of adaptive equipment, the simplification of task sequences, or the modification of the client's household to accommodate for their upper extremity mobility impairments. For the daily activity of feeding, there are many adaptive devices occupational therapists could introduce to an individual with man-in-a-barrel syndrome to help ameliorate the activity due to their upper extremity weakness and limited range of motion. Some of these devices include angled utensils, swivel utensils, and the universal cuff. The top image shows examples of angled utensils, which allow individuals with limited range of motion to bring utensils to their mouth for feeding. Swivel utensils, as shown in the middle image, also ease challenges of feeding for individuals who experience spastic movements and weak grip strength. These swivel utensils prevent spills by keeping the food level when being brought to the user's mouth. Finally, the universal cuff is shown in the bottom image. This allows individuals facing challenges with grip and object manipulation to secure items such as a fork or a spoon. These examples of adaptive equipment may assist in the client's ability to engage in the ADL of feeding through the modification of tasks to improve his participation and performance in the occupation, as well as improve his personal health and quality of life. As mentioned previously, man-in-a-barrel syndrome affects an individual's upper extremity strength, which includes brachial weakness, manual weakness, and challenges with range of motion. These symptoms make ADLs that involve personal hygiene and grooming difficult as well. Some adaptive equipment may be helpful to reduce barriers to engagement. One example of these includes the universal cuff, as mentioned in the last slide. For providing adaptive techniques in the ADLs of personal hygiene and grooming, and bathing and showering, the universal cuff can be of assistance with the use of a variety of devices. The universal cuff can attach onto a toothbrush, hairbrush, handheld shower, and deodorant. The universal cuff can also assist in other areas of occupation, as it can attach to a broom, pens and pencils, and other tools the individual may use. Man-in-a-barrel syndrome diagnoses can cause significant challenges in occupational participation. This is especially the case in occupations where bilateral arm strength and function are of use. The progression of man-in-a-barrel syndrome is influenced by the prognosis of the disorder it was caused by. Cases of man-in-a-barrel syndrome that have etiologies from post-operative hypotension have found good prognosis of bilateral function several months after their surgery. Cases of man-in-a-barrel syndrome that are from spinal lesions after spinal surgery have found good prognosis within 8 months after interventions from physical therapy and occupational therapy. Man-in-a-barrel syndrome after cervical medullary infarct have found prognosis to be dependent on the size and location of the client's stroke. Cervical medullary infarct can lead to residual myelomalacia, which can further affect motor disorders. If the etiology of the man-in-a-barrel syndrome is not treated primarily, the individual can experience further challenges with occupational participation. When the etiology is treated primarily, the occupational participation can improve over the course of intervention. And these are our sources.